Tumors of the bone. Radiological appearance of bone tumors. When looking at bone tumors on a radiograph, as the following question. Radiological feature a bone tumors. Is the tumor created bone or destroyed bone? Is the cortex of the bone intact, broken, or eroded? If intact, is the cortex thinner than normal, and if so, has it been indicated from outside or inside of medullary cavity? Is the medullary cavity wider than normal? Does the shape of tumor suggest that it is lifting the posterior of the bone? If it is, there may be a small triangle of bone at the edge of the tumor, known as the Codman triangle, which is often seen in malignant tumors. As the tumor is fusiform, is the an onion skin appearance. There is often rapidly growing lesion. If the anathynary radical calcification is often seen as a tumor's particular osteogenetic structure. Within tumors, cortical bone islands. Small masses of cortical bone then develop as normal long bones and are of no particular significance apart from their skin appearance of radiographs. Non-ossified fibroma. Non-ossified fibromas. Small areas of fibrous tissue persisting of the long bone are visible of radiographs as cavity rather than the dense opacity of cortical bone island. The condition is important and should not be confused with a genuine tumor. Non-ossifying fibroma. Non-ossifying fibromas are common developmental abnormalities believed to occur in 35% of children, usually an incidental finding, generally occur in the metaphyseal region of long bone in individuals 2 to 20 years old. Although any bone may be involved, approximately 40% are found in the distal femur, 40% in the tibia, and 10% in the fibula. Most non-ossifying fibromas are asymptomatic, regress spontaneously in adulthood. Most pathological fracture can be treated non-operatively. Lesions may become symptomatic and require treatment if they become large or if they are subjected to repeated trauma. The non-ossifying is considered to be a large form of the fibrous cortical defect seen in the lower extremities of children. The lesions are usually eccentrically located, but the large ones can become more central. Radiographically, they have a soap, bubbly appearance with slight thinning and dilatation of the adjacent cortical structure. The diagnosis can usually be established by X-ray alone without biopsy. These lesions are a common cause for pathological fracture in children. They are usually asymptomatic until the day of injury. There can be multiple lesions in the same patient, similar of fibrous dysplasia, and can even be associated with KFA or late skin lesion. Histologically, the lesion consists of benign fibrous tissue speckled with giant cells, histiocytes, and occasional foam cells, and even cholesterol deposits. Treatment usually consists of treatment and bone grafting in high-risk athletic males. Well-defined lobulytic lesion located eccentrically in the metaphysis. Particularly appearance of ridges in the bony wall, sclerotic, scoleptic borders, and erosion of the cortex are frequent findings. There is no periosteal reaction in the absence of a pathological fracture. Solitary bone cysts. The use of the word cyst to describe a hole in bone of the radiograph is misleading because implies that the lesion is hollow, while in fact it may contain solid but uncalcified tissue. Nevertheless, solitary bone cysts do occur usually in the shaft or long bones and cause pathological fracture. Cysts sometimes appear following a fracture, but they can recur even after through curettage and packing with cancellous bone chips. Aneurysmal bone cysts. Aneurysmal bone cysts contain very vascular tissue, and develop in cancellous bone. The lesion expand the bone and look radiologically a little like an aneurysm. The lesion usually fill in and disappear after biopsy or grafting. Achondrometer. Cartilage tumors within a bone are called achondrometer, and like bone cysts cause pathological fracture. Multiple achondrometer occur the earlier disease, in which the lesion caused insanely swelling on the fingers and toes, as well as pathological fracture. The swellings may need to be left in order to improve the appearance and function of the hand. Chondrosarcomata can occur in this lesion, and rapid increase in size should be regarded with suspicion. Achondromatia. Cartilage tumors laying outside the shaft of the bone are called achondromatia. They are benign but may need to be excised if they interfere with the movement of tendons. Exostosis. And exostosis is benign outgrowth of bone. There are two types: lumps of healthy bones, such as the first metatarsal head, heel, or dorsum of the foot. They are congenital in the origin and don't become malignant, but may need to be removed if they interfere with shoe wear. Osteoid, osteoma, and osteoblastoma. A small bleb of very active osteoid tissue can develop in small cavity inside cancellaries or cortical bone. The surrounding bone becomes dense and sclerotic. Radiographs show a small dense mass, perhaps only 1 to 2 millimeters in diameter, lying in the cavity surrounded by sclerotic bone. The lesion causes severe pain out of the proportion to their size. Diagnosis can be difficult, but an isotope scan will usually show up the lesion as a hot spot because the osteoid tissue is much more active than normal bone. CT scans will show the nidus and surrounding sclerosis. If the nidus of osteoid tissue is large, the lesion is known as an osteoblastoma. Excision of the tumor relieves the pain, but finding it is notoriously difficult. Multiple neurofibromatosis. Multiple neurofibromatosis, or Recklinghausen-Sens disease of nerve, involve many specialties. The disease is inherited through the autosomal dominant gene. From an orthopedic standpoint, it has three important implications. The neurofibromatosis can mimic discs, prolapse. The disease can be accompanied by scoliosis. A plexiform neurofibromatosis within bone cause repeat bone resorption and sometimes called Venetian bone disease. Although rare, these create serious problems, and restoring the absent bone may prove impossible. An infected limb can overgrow and become too large. Malignant tumors. The commonest malignant bone tumor is the secondary deposit. In the past, follicular carcinoma of the thyroid has been included in this list, but the tumor is so uncommon that metastasis from it are very rare, very rare. Any of tumors in the list which follows can present with metastasis before the primary identified or many years after it has been eradicated, so that the possibility of the metastasis may be overlooked. Tumors which metastasize to bone most often: lung, breast, prostate, renal cell carcinoma. Treatment. Treatment depends on a tumor but may involve radiotherapy, cytotoxic chemotherapy, or hormone therapy. If a pathological fracture occurs, intramedullary nailing may be needed. It is sometimes wise to nail a bone prophylactically if it seems inevitable that a pathological fracture will occur. Osteogenic sarcoma. Osteogenic sarcoma is malignant tumor occurring at the growing ends of the long bone in children and young adults. The tumor presents as a swelling, and there may be a history of trivial injury. Trivial injury. Osteogenic sarcoma is rare, with an incidence of approximately 1 per million of the population per year. The average orthopedic surgeon is likely to see 3 or 4 during his professional lifetime, and the general practitioner may see none. Treatment is by chemotherapy, radio therapy, amputation, or combination of all this, and should be conducted in close cooperation with an oncologist. The survival rate is approximately 30%. Peristyle sarcoma. Peristyle sarcoma is also osteogenic and similar is distribution to osteogenic sarcoma, but arises from the osteoblastic layer of the periosteum instead of bone. Because peristyle sarcoma arise from periosteum, they lie outside the bone and look different from osteogenic sarcoma. They are also slower to metastasize, which means that the prognosis is not as bad. Tumors of the bone marrow, myeloma, and plasmacytoma. Malignant tumors with the plasma cells, myeloma occur in patients over age of 40 and is commonest cause of clean, punched out hole in bone in this age group. The skull and vertebral bodies are most often involved in the tumor, as usually involved several sites by the time the diagnosis is made. Bone involvement is the commonest presenting feature of the disease, and orthopedic surgeon must make the diagnosis. Investigation. The plasma protein and rises, and the diagnosis is confirmed by high levels of immunoglobulin or electrophoresis. Treatment is by radiography, radiotherapy, and solitary and chemotherapy if multiple. The median life expectancy in 3 years. Ewing sarcoma. Ewing sarcoma rises from bone marrow and occurs most often in patients below the age of 30. The lesion metastasizes early and is more malignant than osteogenic sarcoma. The tumor may arise anywhere along the length of a bone. The radiological appearance include bone destruction, soft tissue swelling, and onion skin layering of the periosteal reaction. Onion skin layers is often associated with malignancy, especially in childhood, and it isn't confined to Ewing sarcoma. Treatment is by chemotherapy with or without surgical resection of the lesion. If the lesion is located and the bone in which it arises can be resected, the patient has roughly a 25% chance of survival. If the lesion can be resected, treatment must consist of chemotherapy alone, which has a survival rate of 5 to 10%. Reticulum cell sarcoma. Reticulum cell sarcoma arises from two reticulum cells of the bone marrow and behaves like Ewing sarcoma, except that it has a more favorable prognosis and occurs in an older age group. Giant cell tumor. The giant cell tumor appearance and multilocular cyst in the epiphysis after growth in the complete and doesn't cross the epiphyseal plate. This tumor can become malignant by its usually benign at the time of presentation. Treatment is by curettage or excision, depending on the site and histology, and bone grafting. Some become malignant and metastasize. Chondrosarcoma. Malignant tumors of cartilage are among the most malignant encountered. The appearance are of cartilaginous mass containing plaque or calcium. Treatment is by amputation when this is possible. The prognosis is poor. Synovial sarcoma. Synovial sarcoma is very malignant tumor arising from any synovium. Treatment. Amputation is occasionally needed, but there may already by metastasis by the time of primary tumors is discovered. Chemotherapy and radiotherapy will be required.